Hmm.
67 years old female residing at Ghaziabad, retired school teacher by occupation, and known hypertensive for last 5 years, got admitted with complaints of low-grade fever for last 4 to 5 months, nausea, vomiting, and loss of appetite for last 10 days, both lower limb swelling for last 7 days, and decreased urine output for last 2 days.
Okay.
History of present illness. Informant is patient herself and is reliable. She was apparently all right 5 months ago when she started developing on and off fever, which was insidious in onset, low grade. Maximum recorded temperature was up to 101 degree Fahrenheit. It was associated with cough with minimal mucoid expectoration, but not with chills or rigors or night sweats. There was no diurnal variation. It was basically 2 to 3 times per week, and it subsided after taking antipyretics. So it was not associated with any sore throat, ear pain, discharge, rhinorrhea. It was also not associated with shortness of breath, hemoptysis, or chest pain. There were
How
no
many times she had to take this paracetamol tablet for the fever?
3 to 4 times per week, as per
3 to 4 times week. And then when she took the tablet, then after how much time she will develop the fever again?
usually after hours. She was not
Maybe
sure.
after?
Hours, 5 to 6 hours. It was not at the same time.
No, why she was taking then 3 to 4 times? 5 to 6 hours means she has to take daily 2 or 3 tablets.
But sir, the occurrence of fever was only 2 to 3 times per week. That kind of fever was there. It was not present every day.
Okay.
It was not associated with shortness of breath or hemoptysis or chest pain. There were no urinary symptoms or altered bowel habits or abdominal pain. There was no weight loss or bone pain. There was no photosensitivity, skin rash, hair loss, headache, joint pain or swelling, muscle pain, any joint deformity or tightening of skin. Also, there was no history of numbness, paresthesia, nasal or oral ulcer, crusting, epistaxis, hematemesis, or malaria. Good evening, sir.
Hello.
Hello.
Yes, please carry on. Hello, Sham.
Hi. Wait.
Sorry, I was late here.
No, quite bad. Continue.
For these persistent fever episodes, she visited multiple physicians, was investigated, and she received multiple treatments, details of which she cannot remember. But at all these visits, she was told that her blood pressure was well controlled with medications. There was no worsening of increase or rise in blood pressure at these visits. So,
worsening means she had history of hypertension before that, or it was normal? What do you mean by worsening?
sir, I have told in the beginning that 67-year-old female, retired school teacher by occupation, known hypertensive for last 5 years.
Okay, okay, chal. I missed that.
So, there was blood pressure was well controlled with medication at these visits. There was only partial relief in spite of the treatment, and her dependency on antipyretics continued intermittently. She was doing well for next 4 months with intermittent low-grade fever, but 1 month ago, she developed sudden onset high-grade fever, which was associated with chills, generalized body ache and weakness, with as many as 2 spikes of fever in single day. She was admitted 2 days after onset of fever. Admission time total was 7 days, and she received IV antibiotics and was discharged when she was afebrile for 2 days. At this time, as she remembers, she was found to be anemic, as she remembers that her hemoglobin was 9 gram %. This time, she was also told that her blood pressure was still under control with medications, which she was taking previously. So basically, then 10 days ago, before this admission, she developed nausea followed by vomiting episodes and loss of appetite, which was insidious in onset and gradually progressive, and low-grade fever persisted. Vomiting was non-bilious, non-projectile, not mixed with blood, but contained food particles. Initially, it was 1 to 2 episodes daily, but later on progressed to 2 to 3 daily episodes over next few days, and it was not associated with any kind of altered bowel habits. So 7 days ago, she noticed swelling in both lower limbs. It was insidious in onset. It was more prominent in evening time as day progressed and used to decrease in the morning when she used to get up. She denies noticing any facial swelling, and this swelling was not associated with exertional dyspnea, orthopnea, or PND. For last 2 days, she complained of decreased urine output. In this decrease, she is unable to quantify, but she is passing urine less times. Before she used to pass approximately 4 to 5 times, and now she is passing only 1 to 2 times. And this decrease in urine output was not associated with hematuria, burning sensation in urine, or frequency or urgency or backache. She consulted her physician and was told that she was investigated, and she was told that her kidneys are not working properly. And she remembers that her creatinine at this visit was 4.8 milligram per day. She also recalls that her creatinine last admission at discharge time was 0.8 milligram per day. And her blood pressure checked in the OPD at that time was also not high. It was well controlled with her daily medication. So she was advised to visit a nephrologist, and then she got admitted on 9th August 2020. This is the brief history.
Complete history को complete करो. Any past history or any family history or anything which is
Past history. She was detected to be hypertensive 5 years ago on routine evaluation and is on 2 drugs since then. Tab amlodipine 5 mg once daily and tab metoprolol 50 mg once daily. And she, as per the patient, is strictly compliant to her medication. She is also known hypothyroid for last 20 years and is currently on tab eltroxin 75 mcg before breakfast. And there is no other significant past medical history as per patient. Family history. Father was hypertensive and died at the age of 80 years due to cardiac ailment. There is no history of kidney disease in her parents or siblings. Then personal history. She has no addiction. She is vegetarian. Sleep is normal apart from last 2 to 3 days. Appetite is reduced. She is married with 2 children, aged 40 years and 46 years. She has reduced urine output for last few days. This is the personal history.
any history of vaccination?
But she hasn't taken COVID vaccination because she was running on and off fever, low-grade fever. So
She is not vaccinated.
yes.
Okay, so just summarize and history and then make your diagnosis, differential diagnosis.
Sir, a 67 years old female with well-controlled hypertension on medication is running low-grade fever for last 5 months. She is found to be anemic 1 month ago and has new onset edema and decreased urine output for last 5 to 7 days with rising creatinine, which is indicating that this is most likely rapidly progressing renal failure.
So what is your syndromic diagnosis? Rapidly progressive renal failure.
Yes, sir.
And what is the cause of rapidly progressive renal failure?
But she is running fever for a long time. So this is mostly a glomerular disease because she is having edema, decreased urine output, and there are urinary.
What the fever has to do with the glomerular disease?
So it may be secondary glomerular disease, not primary glomerular disease. So it is basically associated with some systemic illness. So my diagnosis in elderly female presenting at this age will be the most likely small vessel vasculitis. In this case, ANCA vasculitis I will keep as the first differential.
ANCA vasculitis. Directly ANCA vasculitis. No history of joint pain, no history of rashes, nothing. She is having these symptoms for 4 months. Can't it be some infection and she has taken some drug and which precipitated this?
But it can be.
Do you know the diagnosis of this patient? If you know the diagnosis of this patient, then it's really disaster. So,
My second is infection related GN, sir. The focus of infection is not yet known. We need more meticulous investigation to find out the cause. She was admitted, she was evaluated, but still we could not identify the focus of infection in this case.
infection related GN.
Yes, sir. That is
What is
second.
infection related GN? How you make a diagnosis of the infection relation GN?
Sir,
How much
basically,
time after infection patient develop glomerulonephritis?
sir, it can be if there is suppose there is sore throat or pharyngitis, then it develops usually 1 to 2 weeks after that. If there is some skin involvement, then it takes 3 to 4 weeks to develop after that, usually.
Does the course of this patient tell you about this patient has any of these things?
Sir, 1 month ago, she was admitted with high-grade fever. And at that time, we were not able to examine her, but she was admitted. And she received IV antibiotics also for that.
What about 4 months fever? No, you are making a diagnosis of that 4 months fever, and then so that was some acute infection which get resolved with the antibiotic probably.
Yes, sir.
So what type of the infection related? What is the classification of infection related glomerulonephritis? So are you talking of the PIGN or infection related glomerulonephritis? That is different. That occurs, I think, after only few days. It does
Yes,
not take weeks. So weeks to this is post-streptococcal. After 2 to 3 weeks of the throat infection or 4 to 6 weeks of the infection is the post-streptococcal. So that is a separate thing. And infection-related glomerulonephritis is
okay.
that it developed within few days. So does this patient fits into any of these?
No, sir.
So, so, so would you like to keep this diagnosis or you would like to keep some other diagnosis? What are the causes of the rapidly progressive renal failure?
Sir, rapidly progressive renal failure, we can go by compartment, like vascular compartment is one, then glomerular compartment, and then tubular compartment. In that way, apart in glomerular compartment, apart from that, other things.
Tell the causes. See, you have told the 3 compartment. Now tell me the name of the diseases which can cause RPRF.
Sir, in vascular compartment, thrombotic microangiopathy can cause. Then, apart from that, malignant hypertension is there. Then it can result in, or if there is any scleroderma, renal crisis, vascular compartment. These are the three causes. And then there can be atheroembolic disease that can also present.
Okay, so does this patient fits in any of these?
Sir, because there was no worsening of hypertension, so any vascular disease should have increased blood pressure. But in this case, she has maintained her blood pressure. It was never worsened.
So that's what I am asking you. Would you keep any of these diagnoses as a differential in this patient?
No, sir.
No. So other causes then come to other compartments.
Wherein glomerular compartment, apart from vasculitis, there is a possibility of monoclonal gammopathy of renal significance, elderly, female unexplained renal failure. She is having fever, she is having anemia. So,
Why are you telling renal significance? This usually occurs in patient with multiple myeloma.
yes, sir. But
MDRS is a different diagnosis. That means you have
multiple,
patient has proteinuria, nephrotic syndrome, and then you find out, and there are no other systemic features. Means
because
I don't know whether MGRS is in the classification of the RPRF. Ravi, are you aware? I don't know. But recently, I don't know about because the classical thing is that multiple myeloma is one of the causes of the RPRF.
I think when we are discussing, we should. I'm audible.
Yes, yes.
Yeah. So when we are discussing, we should say multiple myeloma as a differential, not MGRS. Actually, MGRS would include multiple myeloma. Any plasma cell dysplasia with significant involvement of kidney, whether it's light chain, whether it's a deposition or infiltration, it's a MGRS. Okay, but when we're discussing, well, coming back to your history, actually, you should analyze more from the history. You have said there's an elderly lady who was hypertensive for 5 months or more. I don't know what was the duration of hypertension?
her hypertension was for 5 years.
5 years. Okay. So she had hypertension for 5 years and now she has some edema which is coming for now a month or so, fever for 5 months, a low fever for 5 months. And in the end, last 1 week, the renal failure is worsening and there's some decreased urine output and all. So now do you want to club all these findings in one renal diagnosis? How would you explain? Like when she was having hypertension for last 5 years. So do you feel this part of the renal disease? She had a secondary hypertension or it's an essential hypertension. Now she has a renal disease. First, you start first complaint and you analyze. Because suppose you're saying, I'm giving you an example, that this hypertension is a part of the renal disease, then keeping a diagnosis of a vasculitis is very unlikely. A patient of small vessel vasculitis can have a fever, can have hypertension, but it's not likely to survive that long.
Yes.
5 years like that without any treatment, without any systemic involvement. So try to analyze the history. Suppose we say if it's a 5-year hypertension, maybe she has a chronic kidney disease
Yes,
and
that is in the other syndromic diagnosis.
because she has no edematous illness, so it's maybe interstitial nephritis or interstitial
Yes.
chronic kidney disease, and she had some hypertension, and now she's landing up in a condition where now kidney is giving away. Okay, it is a stage where there's an advanced renal failure. She has anemia. Chronic interstitial nephritis patients have a more anemia, more acidosis, and now it's a time when this is becoming symptomatic. Does she have hematuria? Is
No,
there any
sir.
history? So there is no history of hematuria. So a hard point to differentiate between RPGN, RPRF, RPGN is a hematuria. So there is no such history, and episodes of accelerated hypertension and oliguria. So it's only in the end now. So I'm trying to just give you the context. Always when you analyze a case, go symptom by symptom and try to analyze where you can, in which disease you can fix them, and don't try to jump to a diagnosis because you know the diagnosis. That is actually as Dr. Sham also said, it's the worst way to present, and then you will be in a soup, because how you can reach the diagnosis, there's so many things. So what do you feel? The hypertension was part of a chronic illness? She has a CKD? What do you say?
But she is not having any CKD symptoms as per the history, and there is no evidence for the cause of CKD in this case. There is no other illness.
So there are so many patients who will present to us with advanced renal failure and hypertension. They were asymptomatic, now in the last 15 days started having symptoms. So that is a very common presentation of chronic interstitial nephritis of unknown origin or chronic pyelonephritis if patient had previous episodes of infection. Use of ACE in the NSAIDs. Patient can have a long-term history of NSAIDs. She's a lady, elderly, she may be having pain medicines for joint pains. Did you ask? Did she have any pain medicines for joint pains?
So she was saying she only took paracetamol. Apart from that, she took
Okay.
any
So I'm giving a perspective on those lines. Now coming to the present situation, suppose you're keeping a diagnosis of rapidly progressive renal failure. Now, how do you explain the fever for 5 months? And how do you correlate this with the diagnosis? What is the cause of that fever? Because your history never gave anything positive because it's significant finding, 5 months of fever. So what is your opinion on the fever?
So she is running low-grade fever, so it may be a constitutional symptom of some systemic disease, which she is running together with it.
Okay, so first thing is when patient says fever, you ask them, have you measured the fever?
So she has checked the maximum recorded temperature was up to 101.
Okay, so if she has there is a significant fever for 5 months, what are your differential for that?
So for differential for that, there can be chronic infection, like she might be running any tuberculosis or something.
Yes, so two things in elderly with low-grade fever for long term, tuberculosis and malignancy.
Malignancy.
So that thing is it is a reflex. These are the two main causes. So
but she was evaluated over the time period and she was not
found to have. So, and vasculitis can have fever. Vasculitis can have high TLC also. So that is also there. Okay. Third part was that post-infective would have a correlation, the fever is occurring, there's some gap, some nephritis is occurring, and the history will be shorter. So long 5 months history of fever and now presenting like this is unlikely. Okay. So now coming to the, suppose you are keeping the differential as a rapidly progressive glomerulonephritis now. The question was that what are the causes and which cause fits best. So in a 67-year-old lady presenting with a rapidly progressive glomerulonephritis, what if I say 100 such patients are there, which is the most common cause, which is the least common cause? By virtue of her age is in the 6th decade, 7th decade, what are the common cause?
By this age, vasculitis, vasculitis is very common. Elderly female is
How common? How common? 10%, 20%, 50%? How common? Okay, it is very common. It's now 80%, 70-80% patient presenting with RPGN at this age will be vasculitis. So your guess is not wrong if you say it is going to be a vasculitis, because it is a very common cause in this age group. But if you say a inflammatory, a proliferative nephritis, whether it is a low C3 or normal C3, proliferative nephritis, less chances, and so is anti-GBM disease. They are very less, maybe 10-15%. So that is a good way to answer that, if you can describe all this. And then there are mimicking conditions like accelerated hypertension, TMA, HUS, preeclampsia is not in this age group, but then APLA also can present like that. So these are the conditions you should keep in mind. So coming back to the case now, so after all this discussion, are you any wiser? What is your differential now, and how do you, what are their diagnosis now?
Sir, because ANCA vasculitis is very common, I will keep it as the number 1. And then second, I can keep MPGN as a possibility, membranoproliferative GN. And the third one, though anti-GBM.
Proliferative GN is any new classification? This term is used?
No, sir, this is only a histological diagnosis. C3 in this case will be.
So how would you make a histological diagnosis on the clinical history taking? MPGN is not a diagnosis now. So MPGN, so it's only a pattern of the injury histological. Okay, you would not use MPGN term, this thing. You have to.
C3GN.
So one thing is that you have made a diagnosis. This is very common. It is a common cause, most common cause of the RPGN in this age group. So it's not very common as such in general population. It is a most common cause of RPGN in this age group. What is the second and third common cause of RPGN behind after this?
Apart from this, anti-GBM disease is also a possibility.
Anti-GBM disease. The anti-GBM disease can occur at this age. There are 2 peaks of the anti-GBM, second decade and the 7 decade, 6-7 decade. So there is if you are keeping a possibility of the RPGN, then there is a possibility of the anti-GBN cannot be ruled out. Third is?
Sir, lupus nephritis at this stage is not that common. So I will
not common. No, so you should not. You should third. What is there are 3 classification: post-immune, anti-GBM. Third is immune complex. So we are talking immune complex glomerulonephritis. So what are the various diseases in immune complex glomerulonephritis which can lead to RPGN type of presentation?
In immune complex, infection related also falls under immune complex only, whereas deposition. And apart from that, lupus nephritis is also part of immune complex. Then hypocomplementary vasculitis, that is also.
Complementary vasculitis, what is this? You can say C3 glomerulonephritis, one possibility, anything, any glomerular disease which can present with crescent. So I'm just asking you, these are the 2 causes which I mentioned, which you mentioned. First is ANCA vasculitis, obviously the most common, and anti-GBM disease. So what are the various diseases in the immune complex glomerulonephritis which can cause crescentic GN? So if you are talking of the RPGN, it means the patient most likely has crescentic glomerulonephritis, isn't it?
Yes, sir.
So what are the various causes of the crescentic glomerulonephritis, immune complex mediated? One is you mentioned lupus nephritis.
You've already mentioned few of them.
Maybe.
So why are you not able to spell out? You have said PIGN, okay, post-infective. You have said a lupus.
I have told infection related.
Sepsis associated. What else? C3. You have told C3 nephritis.
No. I don't know. Sepsis associated what? Means crescentic glomerulonephritis. We are talking about PGN or what?
Infection associated is saying.
Infection associated. Okay.
What else? With normal C3?
ANCA vasculitis, we have already said. ANCA,
No. IgA nephropathy.
IgA nephropathy with crescent. Yes, sir.
So
Okay.
you should know all these things. See, the fever is one thing you forgot from your history is when Ravi was asking about CKD. Go boy, because many patients can present without any history or a history of only 2 or 3 week duration. The point against the CKD in this patient was admitted 3 weeks back before this admission, and her serum creatinine was normal. It was checked at that time. So at that time, she did not have any renal dysfunction, which is a clear-cut history. She is an educated lady. She knows her value. She remembers what was the creatinine value last time, what is the creatinine value this time. So this is fits into the picture of the RPRA,
Yes, sir.
not CKD. By this history, you can say, because there is nothing else such as hypertension. She had essential hypertension. Hypertension is very common, essential hypertension at this age. Her blood pressure was well controlled for 5 years, and now she developed these things. So obviously, your diagnosis would be rapidly progressive. Now you have to see out various possibilities. So what else? So this becomes the glomerular compartment. Then what else? Third possibility you said interstitial. What diseases in the interstitium which can cause RPRF?
In acute interstitial nephritis, she has history of intake of lot of drugs because she has received multiple treatments, and recently also she received IV antibiotics, and also fever because of any reasons, disease which she is having. Sometimes some infections like tuberculosis are also associated with AIN, granulomatous interstitial nephritis. So that is also a possibility.
So what is against the diagnosis of the acute interstitial nephritis? Why haven't you kept it as a second or first cause? What is the problem in the history and your diagnosis and the presentation?
Because patient is presenting with edema. So,
Any patient who would have advanced renal dysfunction,
edema, yes, sir.
if the GFR falls below 10, most of these patients would have oliguria and edema. Where it is written that a patient with interstitial nephritis will not have any oliguria or edema.
But sir, there is withdrawal of the drug and she is still worsening in this case because with antibiotic which she,
It is not necessary that AKIN will always improve with the withdrawal of the offending agent. Why do you give steroids then in the IN?
but first we wait for 5 to 7 days and then we introduce steroids.
No. So this is many people will see that is a very important. If somebody develops AIN and if you patient does not recover, within 2 weeks time, if you don't start the steroid, patient start developing fibrosis, and then they develop into the chronic interstitial nephritis. Have you read about it?
Yes, sir.
So many of these, they will develop this thing. Can it be drug induced SLE because the patient received some drugs when she was admitted and now she presented with this picture?
But it
Which
is
drugs can cause SLE?
hydrolyzin use is associated with SLE.
Hmm.
From that, primapine also, anti-malarial drugs.
So hemolysis होता है. Okay. Any other diagnosis, differential diagnosis in the interstitial compartment?
Acute interstitial because of the severity and that AIN only. And
Okay.
So actually, when you are discussing interstitial pathologies, tubulointerstitial compartment is getting affected. So what are the causes of tubulointerstitial nephritis? Can you tell what is the acute tubulointerstitial nephritis? What are the two representative types? What are the two common modes of interstitial nephritis? Do you know? When you are discussing interstitial nephritis, you discuss about NSAID associated nephritis or or which one? Methicillin associated, penicillin group associated.
Antibiotic.
So these are two representative forms. What is the difference between these? Do you know what is the difference between these two type of interstitial nephritis? So I think you should read up interstitial nephritis. So one is, these are the causes. What are the other causes? Whenever any cause you are discussing, you have to discuss connective tissue disorders, infections, malignancies, hereditary disorders, and unknown things, other rare things. So ऐसे आप कोई भी चीज के जब आप क्लासिफिकेशन बताओ तो सारी चीजें बताओ. ऐसे इसमें भी है. आप कोई, can you tell 5 types of 5 causes of interstitial nephritis? Any 5 which you have seen in kidney biopsy, any 5 cause of interstitial nephritis.
One is infection like tuberculosis, then system like sarcoidosis.
Okay.
Drugs.
Okay.
Apart from that,
multiple myeloma.
Multiple myeloma, yes, sir.
Pyelonephritis.
Pyelonephritis, yes.
Okay. So you should be able to tell these are some causes you have seen in the biopsy. So
IgG4 related disease, that is now one should always consider if renal disorder.
Yes, sir.
So out of these, which one you feel may be there in this patient? If you are
most likely drug related, because she has taken a lot of drugs and she was recently admitted also.
You said she's a very educated lady, she knows everything. What are the drugs she used? What medicines she was on?
At this admission, she was given IV antibiotics only, but she doesn't remember which antibiotics. And before that also she has taken antibiotics majorly, oral antibiotics. She has received Augmentin before, she has received azithromycin. Once she has received, these are the main.
Okay. Dr. Sham?
Yes. Yeah. Yes. So why don't you complete the examination? Is there any positive finding in the examination?
During my examination, so I will complete it briefly. On examination, she was conscious, alert, oriented to time, place, and
just tell her any positive finding. Does she have any positive finding in examination?
she was febrile. Temperature was 99.6 degree Fahrenheit.
Okay.
And pedal edema was there up to shin, which was pretty non-tender and not warm, and she was having pallor. JVP was not raised. And apart from that, the respiratory system examination was normal. In severe apex beat was noted to be in 5th intercostal space, just middle to mid-clavicular line, no special character. S1, S2 was audible with no added sounds or murmur. In CNS examination, cranial nervous sensory system was normal. Fundoscopy examination revealed no hemorrhages or exudates.
No, the thing is that this patient, if you are making a diagnosis of the vasculitis, and there's a peripheral neuropathy in vasculitis, so what is the this? Have you done this sensory and motor examination?
Yes, sir, I have done, but at present it was not there.
No, what? It was normal, or you have not done the examination? What?
It was normal.
No, it's very difficult. So if the patient was having this vasculitis for 4 or 5 months, these patients sometimes have severe neuropathy, and we have seen these sort of patient. So if there is a real physical examination and the examiner finds some finding, then this is going to be a disaster. This is the only important thing in this patient to be examined physically, because you can't just say it is normal. I don't believe if somebody has vasculitis going on for some time, the CNS examination and the peripheral nervous system examination is going to be absolutely normal. Okay, so urine.
Urine routine examination revealed 3+ protein, 20 RBC, 5 WBC without any cast.
Without any cast. So what are your differential diagnosis? Three differential diagnosis for this patient after your physical examination.
Sir, because there is proteinuria and she is also passing RBC
Hmm.
and there is also WBC, it's most likely a glomerular disease only.
ठीक है. So what glomerular disease का बहुत बड़ी मैंने बोला differential diagnosis बताओ.
But because she is passing RBC, so it is basically possibility of crescents is there. So it is crescentic glomerulonephritis is a possibility.
यार clinical diagnosis बताओ, histological diagnosis मत बताओ. Clinical diagnosis क्या होती है?
Proliferative glomerulonephritis.
अरे यार ANCA associated
ANCA vascular.
बता रहे तुम.
Yes, sir. ANCA vascular.
This become first diagnosis. And what else? क्रिसेंट तो सब में होंगे. क्रिसेंट तो एंटीजीबीएम में भी होंगे, इम्यून कॉम्प्लेक्स में भी होंगे, एसएलई में भी होंगे, आईजीएम में भी होंगे. सो दिस इज द डायग्नोसिस.
ANCA associated will be first, then lower down I will keep immune complex also. But because other history is not supporting, an anti-GBM is also a possibility.
नहीं, ये तो तुमने क्लासिफिकेशन बता दिया. इम्यून कॉम्प्लेक्स हैज 10 डिसीजेस इन दैट. We are asking for the specific diagnosis. This is not the time for the. फिर तो कोई जरूरत ही नहीं. आप just to make a diagnosis of the crescentic glomerulonephritis सारी आ जाएंगी फिर उसमें. एंका भी आ जाएगा, एंटीजीबीएम भी आ जाएगा, इम्यून कॉम्प्लेक्स भी आ जाएगा.
C3GN is a possibility. So ANCA,
C3GN is common.
not
So
that common. No, sir. So IgA nephropathy with crescents is second, I will.
IgA with crescent.
Yes, sir.
Why not SLE with crescent? This patient had history of fever for 4-5 months. Why with the patient with IgA nephropathy with crescent had fever for, if you are correlating with one illness, one disease?
Lupus also I will keep at third or fourth because she is elderly, age group is not that common, so I am going against it. Otherwise,
No other systemic feature of lupus, obviously. So, would you not like to keep a possibility of the AIN?
yes, sir. AIN is still a possibility.
Microscopic hematuria not seen in AIN?
It can be seen.
It can be seen. How common is it? It is commonly seen. It is not uncommon. This is common. Few RBCs and pus cells, WBC, they are common in acute intestinal nephritis. It's not uncommon. Ravi, yes.
So, okay. So now, how will you investigate the patient? What investigations you want to be done?
But I would like to quantify the proteinuria also. So urine for protein creatinine was 0.48. Then I would like to look at the
आप orthodox way में बताओ ना. Start with the hemogram. Say I'll do a hemogram. What is hemoglobin level, TLC levels, platelet counts, like that.
But I will do a complete hemogram.
बताते जाओ, values भी बता दो आप, इसकी साथ साथ बता दो.
Hemoglobin was 9.8, TLC was 10,000, platelet was 3 lakh. And then I would do KFT. In KFT, creatinine was, she was admitted on with us on 10th. On 9th, her creatinine was 4.8. On 10th, her creatinine was 6.30 on the day of admission. Urea was 210, sodium was 132, potassium was 5.7. In LFT, sir, it was almost normal. Then apart from that, C3, C4.
What was the albumin level?
Albumin level was 2.8.
How is it significant?
Basically, it indicates chronicity maybe in this case and negative marker of inflammation both.
Okay, so mainly if there's a proteinuric disease for a longer time, so albumin will be low.
Yes.
Okay.
And globulin was 4.1. Ratio. And calcium was 8.14. Phosphate was 6.62. And total cholesterol was 186. So, radiological investigation, USG was, whole abdomen was done. Right kidney was 9.2 centimeter. Left was 9.8 centimeter. Echogenicity was increased, but CMD was maintained. Other blood tests, ANA was negative. Free kappa was 147, free lambda was 47.5, and ratio was 3.11. And SPEP, there was no M spike. Apart from
ratio was 3.1.
Yes, sir.
Okay.
So is it normal or it is abnormal?
For increased creatinine levels, the normal range is increased, is higher. So
No, we are talking about ratio. Normal range is increased, that is fine. But what about the ratio? What is the upper limit of the ratio?
it is 0.25 to 1.65. So it is higher than 1.65. So it is 3.11 in this case.
Why did you get this test done? You have not kept a possibility of the myeloma. You said that this is a glomerular disease.
No, sir, I kept MGRS also as a possibility in that case. That MPGN also can, in elderly patient, can have some monoclonal gammopathy underlying, which is some clone is there. So that possibility was kept. It was unexplained renal failure.
No, in final diagnosis, you did not keep this possibility. Well, that is fine. So what will you do further? What is the urine protein creatinine ratio or 24-hour urine out urine protein?
Spot urine protein creatinine ratio was done, that was 0.48.
How much?
0.48.
0.4.
0.48, yes.
So then, what does it suggest?
That there is not much proteinuria is there. It is,
Do you still consider this is a glomerular disease or no?
yes, sir, because presence of RBC is there and I will still favor it to be a glomerular disease. 0.4, 0.5 spot urine, we consider it as up to normal. So 0.48 is approximately.
The point for it was glomerular proteinuria. What is the glomerular proteinuria? What is the range of glomerular proteinuria?
In spot collection, you are asking, or 30 classification is there. But
glomerular disease में अगर advanced glomerular disease है, so is this
usually more than 1 gram should be there on spot urine. More than one should be.
it's a more than 2 gram use. It's not even one. If somebody has glomerular disease, especially the if you leave aside the early stages of the diabetic nephropathy or something, when there the proteinuria is starting, most of the glomerular disease they will have proteinuria more than 2 gram.
Yes, sir.
So at least either this report is wrong or this does not favor. If this is a right report, then the chances of the glomerular diseases are very low. If this is report is right, I don't know. What is serum albumin?
2.8, sir.
So your report is wrong probably, but we don't know sometimes. Albumin is acute phase reactant, so it can get low in many diseases. So what will you do further?
Further, we evaluated ANA was negative and P-ANCA was positive. It was 10 international unit per ml. It was done by ELISA method.
10. What is the upper limit? Normal range.
More than 5 is considered to be positive.
And value is 10.
Yes, sir.
So this is very low positive.
Sir, we also confirmed it by immunofluorescence. It showed a titer of 1:20 with P-ANCA pattern.
1:20 तो आपका फर्स्ट डाइल्यूशन ही हो गया.
Yes, sir. It is low positive.
Okay, then
And then C-ANCA was negative, and then we also did anti-GBM. Anti-GBM by ELISA was 613, 613 units per ml. So normal range is less than 7. So it was strongly positive.
so it's anti-GBM disease. So you should always keep a possibility in this age group of the anti-GBM disease. Don't go by the ANCA thing, and this is the most common, but obviously you have to keep a differential diagnosis is very important for any patient. More common, less common, that is okay. But then the causes, if it is ANCA is 60%, then anti-GBM is 15-20%. Even this is the third most common. Second is the immune complex mediated. But you cannot rule it out. That is very important. So what is in the kidney biopsy?
But, biopsy reports are Light microscopy, kidney biopsy in a single linear core revealed 9 glomeruli, out of which one glomerulus was globally sclerosed, surrounded by fibrous crescent. All the remaining tufts show circumferential cellular crescents with evidence of Bowman's capsule rupture. Underlying tuft is compressed in 3 glomeruli and show necrotizing lesions in 2 glomeruli. The non-sclerosed tuft do not show mesangial matrix expansion, mesangial proliferation, or endocapillary proliferation. No membrane thickening was seen.
IF.
Yes, sir.
IF and interstitial chronicity and immunofluorescence.
The tubulointerstitial compartment showed moderate interstitial inflammation involving 26 to 30% of the cortex, and inflammation was composed of lymphocytes and polymorphs. There was diffuse acute tubular injury of moderate degree. No tubular atrophy with interstitial fibrosis was seen. In addition, few tubules show RBC cast. Vascular compartment was only mild intimal sclerosis. There was no evidence of arterial hyalinosis, vasculitis, or thrombotic microangiopathy. On immunofluorescence, IF core contained 10 glomeruli, IgG linear staining along glomerular capillaries and tubular basement membrane. IgA was negative, M was negative, C3 was negative, C1q was negative. And kappa and lambda linear staining along glomerular capillaries, no light chain restriction was seen. And sir, electron is also there.
So diagnosis is clear now.
Yes.
Okay. So I'll just make a quick comment. One is that out of P ANCA and C ANCA, P ANCA you can have more false positives. Secondly, low titer of ANCA is also can be false positive. So whenever you do testing, send all the three anti-GBM, ANCA, ANA, C3. Don't wait that sometimes what we see is we don't send the anti-GBM in active sediment RBGM. You should send anti-GBM altogether. All three causes should be investigated. Rest, I think management we have discussed many times, Dr. Sham.
Yeah. Is the patient dialysis dependent or no?
So dialysis dependent.
So what are you doing? Tell me what are you doing?
Sir, we have done a total of 10 plasma exchange from the time till now, and we have also given cyclophosphamide, IV cyclophosphamide, total 4 doses till now, 500 mg.
4 doses in 1 month. Patient came.
Sir, August, September, October.
So what is the status now? Kidney function?
Yes, she is still oligouric and still
Dialysis?
doesn't recover.
She's on dialysis still.
Thrice weekly dialysis.
So what is your plan now?
Because she had almost 100% crescent at the time of diagnosis, and there was also no alveolar hemorrhage also, but there was no tubular atrophy on the biopsy. So we proceeded with immunosuppressant and plasma exchange.
What is your plan now, 2 months down the line?
So we will continue cyclophosphamide for maybe.
I think you should declare the patient chronic. She has not responded in 1 month time, and you should not subject her to so much immunosuppression. Second is that you should plan for transplant. Then what is she opting for it, or what is the age? I don't remember. So these are the things which need to be discussed. How much time you have to wait for transplant? What is the antibody level? Whether it is improving or not? All these should be discussed. Okay, but I don't think there is any merit in giving immunosuppression to this patient who has not responded 1 month into the illness and presenting at 6, and still remaining oliguric. So that's my inputs. Dr. Sham, anything else?
Okay. So you've tried enough. See, 1 month should be the time to see the response. If the 1 month there is no response, you should taper it out and stop. Especially she had no indication for continuing immunosuppression for so long. But at least stop cyclophosphamide right away, taper steroid, and stop the steroid also in 1 month. Get a anti-GBM titer done. And once the anti-GBM titers are negative, then if she want to go for transplant, maybe after 2 or 3 months, she can go for that. But don't give more cyclophosphamide. She will one day she will end up in the pneumonia and you won't be able to save her. And also get a CMB done, I would suggest, because you are given 4 doses, get a CMB done. Chalo.
I think we'll wind up, Dr. Sham.
Yes.
Okay. Thank you. Thank
Okay,
you,
sir.
Bill.
Thank you so much, sir.
Okay.
Thank you.